Very good afternoon. Let's go into a topic that is may not be very much practicable by each one of you, but then you also have to look back into what a doctor can contribute in a child with autism. I'm not going to touch upon psychopharmacotherapy because we have enough number of psychiatrists who have touched upon it. I'm not going to touch upon it. I'm going to look at other aspects of pediatric care that is needed for a child with autism. This we all know, autism is a chronic condition. A comprehensive treatment approach is needed. We have been discussing on that. We have to have individualized management plan according to the child's weaknesses and use the child's positives to work on the child's weakness. We all know this. Next slide, please. But then we are unable to predict the outcomes, especially in a child who is less than 3 months. Basically, because autism by itself is not a homogeneous disorder, it's a spectrum. So it's a heterogeneous group of children that we are looking at. And our knowledge, I feel, as far as autistic kids are concerned, either etiopathogenesis or normal course, what is a normal history that a person might follow, our knowledge is still a little bit restricted. We are not still come to complete knowledge. Next slide, please. So we also know that early intervention helps. This is accepted. So what is the core of the management? It's basically behavioral and educational intervention, and when there are comorbidities, pharmacological management. There is no doubt about it. No contest on these facts. We all know also that it's a teamwork. The therapist form the essential part. The pediatrician also comes in. The neurologist, psychiatrist, and clinical psychologists also are important aspects. And of late, geneticists are also gaining a lot of importance because we all know etiology, as Meenakshi has pointed out earlier itself, is possibly genetic with a second hit because of environmental factors. Next. So when I look back, what is it that I can do for a child with autism? So as a pediatrician, one, I can definitely do early identification. We had discussed at length, we had a separate program for this last year on early identification of children with autism or autistic features and how to intervene. So that has been that. But over and above that, once diagnosed and they are under regular therapy, these children, like any other child, need routine health maintenance and preventive care. They also need care coordination. They need that one person who can coordinate the care for the child in terms of, psychiatrists, neurologists, all those team. Somebody needs to coordinate the whole thing, and that could be a pediatrician. We also need to, because we are very close to the family, we would have probably known the family right from the child's birth. We are the ones who can actually counsel the family much better than anybody else because we have been there with them right from the time the child is born. Once again, reasserting that the child with ASD needs care like any other child. But unfortunately, in the present day situation, we are not doing this. It might look staggering, but fact is this. They are falling off the grid. We don't have many pediatric visits. One of the reasons is the embarrassment that the parent faces when they come for a pediatric visit. It's very difficult to bring a child with autism into a pediatrician's chamber. And sorry to say, but then some of us may not be that very nice when the child is actually throwing a tantrum. So this becomes a negative influence on the parent, and many of these children are not brought to the OP. So on one hand, we have to look for routine care. On the other hand, we have to also watch out for mealtime behavior because we know these children have, as ma'am had pointed out, sensory issues which will prevent them from eating properly. They may have poor dietary intake. Their physical activity needs to be looked into. Their screen time and hence exposure to sun and hence the bone mineralization also needs to be looked into. And they often have, because of inappropriate nutrition, have very low BMI. All these things have to be taken care of because they come at a higher incidence in a child with autism. Over and above that, we also have to have surveillance. Surveillance for some of the disorders that are very common, much more common in a child with autism than another. For example, seizures, potential genetic disorders, lead poisoning because of pica. All these things are more common in a child with autism. They may have developmental and other mental health comorbidities. We all know autism can coexist with other neurological issues. So we need to screen these kids for them. Autism is not the only diagnosis that the child might carry. There may be other issues that goes unidentified in these kids. Sleep problems. It's a major issue and it often goes undiagnosed. I'm sure Dr. Pungadi had actually educated me regarding this sleep problem a couple of months back with autistic kids, and and one of our postgraduates had done a study on sleep problems. So much so that if we are able to control, if we are able to manage that, we improve the child's quality of life a lot. So how do we manage the office visits? Because we know that is the one that precludes these children from coming to the OP and prevents us from doing all those things. Most important is communicating with the parents. A practice visit to the pediatrician's office without meeting the pediatrician, just show them the place, get them to be familiar, might help. I know that many dentists, Madhavan sir does it, Bhavani ma'am does it, our pediatric dentist does it. So they give time for these children to basically get used to the system. So when they come into the system, we should not immediately hush them into a room, immediately try to poke them. So we need to give them some time to get adjusted, allow the child to manipulate the instruments that are there right in front of them. Keep the instructions very simple. We know they have communication issues, so we can't give complex instructions. We have to give very, very simple instructions. And while giving those simple instructions, we have to give a lot of visual cues. And minimizing portions of examination that are overwhelming. For example, using a tongue depressor to see the throat. If we can avoid it, try and avoid it, because that's going to make the child much more violent at times and make it very difficult for you to continue with your examination. We all know that these kids have higher rates of feeding and eating problems, and an extensive eating history has to be taken. There are a lot of questionnaires on these, and if there is a problem that is identified, a multidisciplinary team, including the pediatric surgeon, pediatrician, nutritionist, ENT surgeon, might have to be working on this child to improve their eating issues, feeding issues. Other than organic problems, these children can also have behavioral issues like failure to thrive, rumination, pica, obesity, anorexia nervosa. These need interventions by themselves. They need to be identified with the pediatrician and needs to be liaised with the other therapists and other specialists who are working with the child and work for a betterment of the child. Next slide. Children also have selective eating. They'll eat, but then they'll eat food with specific texture, with specific temperature, with specific smell. So we need to identify all these things, take the history and guide the parents on how best to ensure that these children get appropriate nutrition. Gastrointestinal symptoms are at a very, very higher level incidence in a child with ASD than in a non-ASD child. So they can have gastritis, they can have GERD. These are two common conditions. GERD is nothing but gastroesophageal reflux disease, where you have commonly called as heartburn, where the child, the food, instead of going from the stomach down to the duodenum, comes back into the esophagus, causing a severe burning sensation, at times aspiration also. There are other conditions like irritable bowel syndrome. Constipation is a major problem. I am sure we have come across enough number of children with developmental issues with constipation, and motility-based disorders and food allergies and sensitivities. GI activity of a child is different, of an autistic child is different. By a lot of studies, they have found out that the way these children metabolize the carbohydrates is different. When you have different carbohydrates in the intestine, you have different group of bacteria that grow. Those bacteria can be pro-inflammatory. That is, they can increase the inflammatory mediators in the intestine and thus cause all those symptoms that you see of irritable bowel disease, chronic inflammatory bowel disease and all can come because of these issues. Gastroesophageal reflux disease, I've discussed on this. Next. The management of GERD is mainly positioning the child, giving small frequent meals and also putting the child on either prokinetics or H2 blockers or proton pump inhibitors like our common ranitidine, pantoprazole along with domperidone. These are the usual drugs that can be used. Chronic diarrhea, that is diarrhea lasting for more than 3 weeks, often happens. One of the common causes for this is constipation. There are other causes like irritable bowel syndrome and all. So these need to be addressed and managed. So you have so many these GI conditions that need to be identified and managed in a child with autism. This is a star question: gluten-free, casein-free diet, GFCF diet. Lot of parents report benefit, but on studies they didn't find much of benefit. In spite of this, a lot of clinicians believe that there is a subset of autistic children for whom GFCF diet might work, not for all of them. But the problem is, which are the ones that we have not identified that. So uniformly generalizing this GFCF diet to every child would mean, what are the side effects of GFCF diet? The child is going to go in for malnutrition. And there is malnutrition, as you will see in further slides. There's obviously going to be less cognition, and you're going to have a much lesser outcome when compared to a child who is not malnourished. So we have to be very careful before we put these children on GFCF diet. We still need more data as far as which are the kids that need to be picked up for GFCF diet. Chronic constipation. During chronic constipation, the rectum starts enlarging. It becomes a bag which is unable to push the hard stools down the anus. So this causes heavy stasis and recurrent infections and diarrhea. Now management for this is mainly, next slide please, initially by disimpaction using enemas. PEG enema is the one that is recommended, followed by long-term laxatives, often for 6 months to 1 year. And dietary modification, giving high fiber diet, high amount of liquids, and once the pain starts coming down, the child should be, behavioral modification needs to be done so that the child can sit in the potty, because that is the position where the pelvic muscles can push out the stool completely out of the rectum. So some of the high fiber rich diets, you don't have to go for any of those fancy over the counter medicines. Regular diet itself can be modified. We have some of the nutritionists here. Some of them have been advising my patients also. Even your cereals that you give, the less processed they are, they contain more fiber. So instead of using white rice, if you use parboiled rice, you will obviously be giving more fiber. So look at simple modifications rather than using very complicated things. Epilepsy. 1 in 4 autistic children develop seizures during their lifetime. It's so common. And they can either happen before 5 years or during their adolescence. And many of these will require medications. It is more common in females. It is also females with autism, and it's also more common in children with intellectual disability. So seizures are a common occurrence. In fact, there are a lot of studies coming up with children who have been diagnosed as only autism, who underwent EEG just like that because they didn't have any obvious seizures, and they found the seizure activity. Once they treated the seizure activity, the outcome started improving in the child dramatically. So there are a lot of anecdotal studies, but then still those studies have not come into mainstream and have not been presented as a series or proper evidence. But then nevertheless, these things are coming up. That's one of the reasons why I feel we still know very little about autism. We need to know a lot more. Developmental coordination disorders, another problem. Somebody was asking me during the tea break, sir, autism is a problem with the mind. How is that these children have motor issues? One of the physiotherapists has asked. We have found, in one of the papers that have also come, that many of these kids have motor coordination. And most of you all would have seen it actually, probably suspected it also. When we do Bailey, we find that these kids do drop in motor scores in Bailey. Bailey is nothing but a routine developmental assessment that we use. Pediatrician run centers mostly use Bailey because we use it for our early intervention and follow-up. And we did find that these kids are falling down both in gross motor and fine motor. So these children often have developmental coordination disorders, and that needs to be addressed for them to improve their outcomes in terms of literacy and also in other integration. Sleep disturbances, as I have told, it's supposed to be because of melatonin dysregulation. So the drug of choice is melatonin. There have been a lot of studies on this, and it has been found to be quite effective. And I think it's a very good choice, but then the criteria for selecting a child to be put on these drugs have to be stringent, and we cannot just like that write these drugs for every other child with autism. Now, coming to two important topics that a pediatrician will always talk. One is vaccination, another is growth monitoring. These are two important aspects of any pediatric care, and two important aspects that concern most parents. In a child who is otherwise normal, a parent will walk in and is more concerned about giving all the vaccines. Whereas a child with autism, the parent is very concerned about giving the vaccines. It's very difficult for us to convince them regarding vaccines. So it's important that we clarify certain myths regarding vaccinations. And when you look at vaccines, vaccines are supposed to be one of the high points of modern medicine. We have been able to prevent so many vaccine preventable diseases. And if you look at our society that was there, let us say 1940s, the number of siblings who are dying out of diphtheria, out of polio, were very, very high. When you look at elders in this crowd, they will remember that their batchmates had polio. Even I had 1 or 2 batchmates who are having polio, but now we don't see many kids with polio. Many a times, because these diseases are not seen now because of the effectiveness of the vaccine, we forget that these diseases exist. It is one of the high points, and many a times autistic kids are denied these important preventive aspects. So, without taking much time, here is the chart. This is from US, data from US. It looks at incidence of a disease in 1 lakh children under 5. With the blue line is when the vaccine was introduced in the general vaccination schedule. You can see as we introduced those vaccines, the disease started dropping in almost to negligible amount. This is same for diphtheria, tetanus, measles, mumps. Next slide. Pertussis, polio, rubella, invasive H influenza disease, invasive pneumococcal disease. All these vaccine preventable diseases, the vaccines have been highly effective. But unfortunately, due to a lot of miscommunication, these children are not given vaccines. It's important that this August gathering takes home this message. There's one message from my slide that you would like to have is vaccines are a must for these kids, as important as it is for any other child. So will vaccine make my child autistic? This is a question. And I have parents with 1 month old who come in, sir, vaccine கொடுத்தாக்க குழந்தைக்கு autism வந்துருவாங்க, vaccine கொடுக்கணுமா, இவ்வளவு vaccine கொடுக்குறீங்களே. So in my questions, so I'm taking up some of the misconceptions. Next slide, now. Even World Health Organization gives how we have to convince a parent. I'm not going to go into those details, but nevertheless, it gives us non-directive methods of convincing parents about vaccination. Right? Some of the myths: multiple vaccines overwhelm my child's immune system. So many antigens that you are giving, it overwhelms. So my child will not be able to respond. This is one of the myths. Each day, we come across hundreds and thousands of antigens. And our body is capable of taking up those antigens. So, by giving those vaccines, we are not going to really affect. This is a big myth. Mild to moderate. My child has got mild cold. My child has got mild diarrhea. So, I didn't give vaccines. So, these are some of the reasons why a parent gives these, does not come out for action. There is no such contraindication. In a study, they found that among 1,047 children who were exposed to an average of more than 10,000 antigens by the time 2 years old, they didn't find any major neuropsychiatric adverse effects. These are all data that is available. Next slide, please. Vaccines do not work. We have seen enough amount of data on how vaccines work, both at an individual level and also at the community level. Next slide, please. Other common myths is parents know best what is best for their child. No, we are the medical community. It's our job not to overrule the parent, but to convince the parent with appropriate data so that the child gets the benefit. Next slide, please. Then there are specific objections. Let me come straight to the objection. MMR causing autism. Next slide. It has been, yes, I'll finish. MMR, this has been traced to 1998 article that appeared in Lancet, which showed that, according to that article, it said that MMR vaccine created altered metabolism in the intestine, causing these children to develop autism. Later, this was found non-replicable. There is a lot of other studies were unable to replicate this data. When they went back into the data, they found that this study was fraudulent. And so they withdrew this study, and even the person who actually wrote the article was struck off the General Medical Council, that is, was unable to practice further. So that's in spite of that, this article keeps going around in magazines and in the internet and in the social media, creating a lot of havoc among autistic children, preventing them from getting vaccinated. Even there were concerns about Guillain-Barré in children with, because of influenza. We all know how influenza outbreak came. A lot of children were denied that only because of such concerns, which were misplaced. Next slide, please. So when you don't give vaccine, there is consequences for the child. Child becomes more prone than their peers. So this child is definitely going to have a much poorer health. Next slide, please. Consequences for the community. When a group of children are not vaccinated, the disease rate starts going up, and it puts pressure on the community, and even the vaccinated group starts getting the disease. This has been found by a lot of studies. So this factor is called herd immunity. When a majority of the children in the community is being given the vaccines, the herd immunity develops and children are protected. But when that is not there, you often get into problems. Next slide. The other aspect is growth monitoring. Next slide. We measure the weight, height, head circumference, and can be used of all age groups. A detrimental environment, poor dietary intake, and exposure to infection causes a lot of morbidity, lack of physical activity, and growth in a child. This leads to poor psychological development and mortality. All these things become exaggerated in a child with autism. Next slide. So how do you monitor? We monitor growth by using growth charts. I've put two growth charts here. One is here, the center lines are here. The children are supposed to come between the center lines with N. And here is the dotted lines are the measures of the child. It's falling in normal range. Whereas here you can see that the child is falling off the grid. It's a very simple method, can be used by anybody, any healthcare worker to monitor a child's growth. So growth monitoring becomes an essential aspect of any pediatric care. Thank you.